Okay, great. Thank you and welcome everybody. I'm happy to introduce our speaker today, who is Heather McLeod. She is a genetic counselor that I've known for many years, from back when she was a cardiovascular genetic counselor at the University of Chicago. She was one of the first cardio genetic counselors when she started there back in 2001, coordinating a research study and starting a cardiovascular genetics clinic. She also has experience when she moved to Atlanta to start a clinic at Bisley Heart Center and has done some telephone genetic counseling over the years as well. Currently, she is the senior project manager for the Sudden Death in the Young Registry, which is a very important project that Heather will tell us more about today. And so I consider her one of the experts in postmortem genetic testing and helping us to coordinate this very important testing for families. And so she's going to educate us today more on this topic. Go ahead, Heather.
Thank you so much, Melissa. It is definitely an honor and a privilege to be asked to speak today, and I hope to share a lot of my experience with you to kind of give you the nuts and bolts of how to work through these cases. In terms of disclosure, financial compensation was provided to me for providing this webinar by Ambry. So our learning objectives today are to describe the steps to identifying resources and building a team to fully investigate sudden death cases, along with reviewing common barriers to postmortem genetic testing. We want to identify cases where postmortem genetic testing is appropriate and the types of postmortem genetic testing that are available. We also want to discuss potential barriers to accessing genetic testing and existing resources. Many of these learning objectives are intertwined, and so they might not go completely in order as we go through the webinar, but we will hit on all of them. So as I said, this is a really great opportunity for me because I've been in a unique position over the last year and a half, and I'm really happy to be able to pay this knowledge forward to you and share what I have learned. I hope it helps you to expand your practice because I know it has helped me to expand mine, including down here at the bottom, you will notice that in the past, I always had a heart with a double helix. And now I have added a brain to my heart just based on my experience over the past years and my work with folks working in neurology. So in a sense, I feel like the Scarecrow and the Wizard of Oz, that now I have a brain. So let's move forward. What is postmortem genetic testing? Well, this is testing that is done after a patient has died. To put it quite simply, why would you perform postmortem genetic testing? Well, there's a number of reasons, but the two most important reasons are to determine the cause of death and to provide more accurate risk assessment and genetic counseling for at-risk family members. What causes sudden death in the young? Well, there are a number of causes. Some can be genetic and some are not. In terms of those that you would find findings on autopsy, considered autopsy positive, you might find aneurysm, cardiomyopathy, congenital heart disease, coronary artery disease, diabetic ketoacidosis, infection, metabolic disease. This is particularly important in the cases that you would see in infants, stroke, and you may have other findings. This list could go on and on and on. You will see that a lot of the cases are cardiac in nature, and those are the cases that at this point we know the most about. Cases can also be autopsy negative after full investigation, and we have some known unknowns. So we know a certain number of those cases are caused by arrhythmias. We know a certain number of those cases are caused by sudden unexplained death and epilepsy, which I'm going to share a little bit more information on. And then we know that some of those cases remain unexplained after the complete investigation of the death. So let's talk about, there's been a lot of focus on sudden cardiac death in the young. And what we know is that in nearly half of cases of victims under 35 years of age, there is no warning signs or family history of sudden cardiac death. In about a third of these cases, there is no abnormality found in the heart on autopsy. Having a child die or a young person in your family die suddenly is a terrible, terrible event. Then not knowing is a particularly heavy burden for families to bear. More recently, we have discovered that there can be genetic causes to these autopsy negative cases. In a study conducted in 2007, it was determined that 35% of young sudden death cases had a channelopathy identified. 10% of SIDS cases can have long QT as a cause. Another unexplained or autopsy negative case that we don't talk as much about is sudden unexpected death in epilepsy. Every year, more than 1 out of 1,000 people with epilepsy die from SUDEP. Similar to our autopsy negative cardiac cases, there would be no signs on autopsy. There's a couple risk factors I want to go over because, like I said before, most of us don't have a lot of experience with SUDEP at this point. If your seizures are uncontrolled, the risk of SUDEP increases to more than 1 out of 150. These sudden deaths in children are rare, but are the leading cause of death in young adults with uncontrolled seizures. While we don't know as much about causes of death from SUDEP, there's current studies funded by the NINDS Center for SUDEP Research that suggest genetic factors may play a role. So at this point, we don't have specific percentages to share, but it is being studied quite closely. If you have patients with epilepsy, the greatest risk factor is frequent seizures, especially tonic-clonic seizures. Other risk factors, again similar to what we see in our cardiology patients for considering them high risk, is diagnosis beginning at an early age, having epilepsy for a long time, not being compliant with medication, stopping or changing medications suddenly. The highest risk period for a person with epilepsy to have SUDEP is between 20 and 40 years old. They're at higher risk if they have intellectual disability or if they have a genetic form of epilepsy, for example, Dravet syndrome. So let's talk about the investigation. This is often, I know our audience is primarily genetic counselors today, so this is often an area where I receive a lot of questions. The most important tool in helping to participate in the investigation of these deaths is your team. I very often get questions about how do you read an autopsy? How do you interpret an autopsy? And my best guidance to you is to build your team. So here's the family with sudden death. There are multiple other parties that you need to incorporate to best investigate a death, particularly a medical examiner, first off, and a complete autopsy. You can request a copy of an autopsy from the medical examiner, from the family. Sometimes the family physician will have a copy. But I encourage you to use the experts on your team to help you read the autopsy because they are written in a different language than we typically speak, and we're not quite as used to how they use their narrative and what they assess. And what is normal and what is not normal. So again, the best thing that you can do is pull experts in and share the cases with them. Have a case conference, discuss the case. I think it's also important to know that a lot of cases don't benefit from the multidisciplinary approach. Perhaps even if a medical examiner is involved, they may not have access to a cardiac pathologist or if there is something in the brain, they may not have access to a neuropathologist. So it's very important to ask questions about who was involved, what was done, and how you can help further coordinate the case. Another question I often get is, how do you develop these relationships? This can be very challenging, somewhat intimidating, and so I'll just offer a couple of suggestions. Of course, one is if you share a case, to start building your relationship with the different medical providers at that point. I have reached out in the past based on media alerts and contacted medical examiners in my area when I've seen a case that I think looks suspicious as a young sudden death that might have a genetic component. Another opportunity would be to attend, if you're interested in connecting with the medical examiners or coroners in your community, is attending their meetings and showing your interest and enthusiasm for working with them in that way. So in general, what is reviewed on an autopsy? There are some general characteristics: sex, height, weight. Typically, the medical records are reviewed. An important thing to keep in mind is to look and make sure, particularly if it's a very young patient, say under 3 years of age, that the newborn screening results were reviewed, looking for metabolic disease. Imaging can be done. This varies greatly across the United States in terms of, is it just x-rays? Is it a full skeletal survey? Some offices are starting to do CT. Typically, there's a gross examination of all the organs, particularly looking at the heart, lung, brain, GI tract, and for signs of infectious disease. And on the organs that appear abnormal, typically there is tissue sampling and histology. There can be ancillary testing, which includes toxicology, hopefully genetic testing, if that's a resource available. And then in the end, there's a final diagnosis. A lot of autopsy reports are written in a narrative, which means you would have to read through the whole paragraph and pull out what is important on your case. There's a lot of challenges to the death investigation process, including in not every situation will a death be reviewed, for one. The case can be denied by the medical examiner. They can not choose to take the case. A death investigation could be led by a coroner, and coroners don't meet the same requirements as medical examiners. Medical examiners are typically forensic pathologists. They're appointed. They're medical doctors. Coroners can be elected. The age at which they're elected depends on what state you're in, and they don't have to be a physician. So in some ways, it's hard to generalize and say what you're going to face in your particular area. It's important for you to understand what system your state uses and what your local jurisdiction uses, because there can be a lot of variation in who's doing the investigations, what their training is, what the practices are in your local area. Funding can greatly vary both within a jurisdiction and within a state, and what laws the cases are subject to in terms of what can be saved, what can be looked at, what can be shared with other experts. So this is a lovely slide that our colleague Samantha Baxter put together, and this further reviews a number of the barriers to having a full death investigation. This is focused on barriers to getting an appropriate sample for genetic testing, which we're going to talk about more in a moment. But the barriers start much earlier with, was an autopsy actually conducted? It's important for all of these cases, particularly autopsy negative ones, to know, were the circumstances witnessed? Was an appropriate sample saved? We advocate that an EDTA tube is the best sample to save for best quality and quantity of DNA. But a barrier that many of us have run into, even in major metro areas, is that EDTA tubes are not available in the medical examiner's office. While this is easy to fix, you have to know whether the tubes are available in order to help them get tubes. The barriers go on in terms of communication, how samples are stored, shipped, how tests are ordered, and how results are given. And we will touch on these more as we go through. But what I think this slide best illustrates is just that there are so many steps and the logistics are so important to do everything right to ensure the possibility of helpful results for a family. So again, this is not subliminal. I really meant that to say that. Save a purple top tube. Like I said, what we would like to advocate is that a purple top tube of blood is saved. This is not always possible for reasons I outlined earlier. So other samples that you could get usable DNA out of include fresh frozen liver, spleen, and heart would be good sources. It's important to check with the lab or DNA bank you're working with to know if they accept tissue samples because it does put some extra work on them. And again, it's important for how those samples are shipped. If they are fresh frozen, they need to be shipped on dry ice. Another possibility are other blood samples. These are not as highly recommended and not guaranteed to work, but lots of times people will offer up, I have a red top tube or a gray top tube. So it's worth a shot. Another area that medical examiners and coroners just love to talk about are blood spot cards. This has been a long-standing process of saving blood in postmortem cases. And again, you can't guarantee based on current genetic testing that you will get enough DNA out of these cards to complete a full panel, but it still is an option to consider attempting. I always recommend to families and practitioners that work on these cases, don't ever throw anything out. Technology is constantly changing, and perhaps in the future, one of these things will work. But it is really, really important to get the samples out of the medical examiner's office. There's no guarantee that the samples will be saved forever, and therefore DNA banking is a really, really important issue on these cases, which I will talk about again in a moment. So in moving this idea forward, a couple years ago, a group of us from the cardiac SIG worked with the National Association of Medical Examiners to put together a position paper about saving appropriate samples for genetic testing. And I think that we are making progress on this and that more offices are adapting this process. But anytime you have a paper, it doesn't guarantee that it will be accepted and used in the field. So we have a lot of room to do education, as this quote demonstrates. There was a recent paper that came out, and one of the quotes was, and this is specific to postmortem genetic testing, barriers exist. One is cost, but just as significant is the ability of the medical examiner to order the right test and communicate the results to the family of the deceased person. The survey used the listserv for the National Association of Medical Examiners to assess any knowledge of genetic testing. They received 48 responses, 79% were medical examiners, and 46% of those were MDs. So in terms of differences in just what people are called, this demonstrates at least on the listserv, that not all of the MEs are MDs. And I think it really, really highlights how much room we have to provide education to the medical examiners and coroners. 87% had no additional training in genetics and did not receive genetics training during their residency. 72% reported counseling families about results, but only 18% knew cardiac channelopathies were overwhelmingly inherited. Only 29% knew most of the conditions were autosomal dominant. 39% knew there was a risk to first-degree family members. We would like to see these numbers change, obviously, and I think we, as genetic counselors and physicians who work in genetics, are in the perfect position to help push this forward. Our role in sudden death cases is, number one, to help with the logistics of these cases, because it's complicated and overwhelming, and to provide psychosocial support to the families. This is a terrible time. Something that often goes underlooked is taking a careful family history and looking for other people in the family who are at risk. Collection of medical records, identifying family members to be screened. Again, coordination with medical examiners and physicians, helping to facilitate genetic testing and or DNA banking before things are thrown away from the medical examiner or coroner office. Warning family members about their risk and referral to additional services as needed. This is all very well laid out in another paper that came out along with the physician paper about genetic counselors and an important resource for families following a young sudden cardiac death. And if you need a starting point of how to work through these cases, this paper is a great resource. So let's move on to what's currently available in terms of genetic testing and or DNA banking. Genetic testing has changed quite a bit over the past couple of years. When I started in cardiac genetics back in the early 2000s, most of the testing, if there was any testing available on a clinical basis, was single gene testing. I think it was mostly fibrillin testing. For our postmortem cases, depending on what stage, it's possible if you only have a blood spot card, you may identify someone else in the family with the condition and be able to get enough DNA from a blood spot card to just do family-specific mutation testing on the deceased. What testing is done is subject to what sample is available and what else is going on in the family. In terms of cases where we have enough sample, most folks move past single gene testing to panel testing. And there is a large variety of panels available for testing at this time. It can be focused on phenotype specific, just specifically a hypertrophic cardiomyopathy panel, a long QT panel, up to mega panels that include 90 to 100 cardiac specific genes or cardiac and epilepsy genes, onto the possibility of exome or genome testing. And I think that as our understanding of these cases expands, the expansion of genetic testing is really going to help, because right now we spend a lot of time looking at the known unknowns or the genes where we know there's causes of death, and hopefully future research will help us better understand where else we should be looking. There's a lot of issues with genetic testing, and I'm not going to hammer too long on this because I know there's a lot of genetics folks on the line. But it bears keeping in mind that with postmortem genetic testing, it's just not the same as testing a living person. The results have huge implications for families. And so balancing that this test could provide the cause of death with how many variants of uncertain significance you're willing to deal with is a big balancing act. If you do large testing, you can end up with compound heterozygotes, and I think we will see that happen more as time goes on. There's a reason that a child or a young person dies earlier and that they are the family that's brought to medical attention. Perhaps it's a second hit. It's important for us to know, is duplication deletion testing done as part of this panel? It's important for families to know it's hard to determine penetrant. New mutations can be identified. And for those cases that we've been dealing with for a while, it's important as things move on to consider, when is it worth retesting a case if there's still DNA available? So I am a big fan of pre-test genetic counseling for families, but this does not always happen. I think this is an important part of the informed consent process and helps families deal with the results in the best way. It's important for them to know that this testing may not be the answer. I think it's important for our colleagues in forensics to also know the testing may not reveal an answer. We also may find out an answer and we may not know what it means. The results can have implications for insurance for other people in the family, and very often cost is a barrier to getting this testing done. So I want to talk about insurance for two reasons. People do get insurance reimbursement for postmortem genetic testing. It takes extra legwork. It's not common at this point, but it's worth trying. So I think it's important to keep on your radar. If postmortem genetic testing is done, it's important for the families to know it can delay the final autopsy. The medical examiner or coroner might wait for results to release the final report. There's also a whole slew of implications for the rest of the family, including the psychosocial aspects, the guilt, fear, anxiety that this might bring up in terms of how far they are through their process, how much they have dealt with the death, at what point they get to you to go through this process. Again, life insurance, will it have implications for their employment? If a mutation is found in the family and they are a pilot or a bus driver. It can also have implications for sports, and participation in sports is a big deal for young children. So it's important to talk about these things before testing, if possible. Post-test genetic counseling, equally important, and I think something that we bring huge value to is just, with all the testing, with all the different options, interpretation of the results is key. And what those results mean to the family, what those results mean to the cause of death, and how that gets worked into or does not get worked into the final diagnosis is going to be an ongoing, very important discussion as we move forward. Like I said before, I think DNA banking on these cases is super, super important. Even if testing is able to be done now, it's important to save DNA for the future because we don't know what we don't know. And it's important to have DNA around as we discover more. I would say this is actually important in all areas of genetics. Even if you're working in cancer or prenatal or some other pediatric disease, I think it's a good practice for us to get into is talking to families about DNA banking so that as we discover more in the future, there's something to go back to. What are the implications for family screening and care? Well, there's been recent guidelines to provide some guidance, again, specific to cardiac disease. In 2013, there was an expert consensus statement released from HRS on management of patients with inherited primary arrhythmia syndrome. So in the unexplained death cases, it is recommended, and this is something that we can help do, it is recommended that personal and family circumstances of sudden death are collected. It's recommended that, if possible, slides of the heart are reviewed by an expert cardiac pathologist. It is recommended that samples be saved for postmortem genetic testing. For the families, it's recommended that if there is a pathogenic gene mutation associated, that they have the option of getting this tested. It's important to have them evaluated. Folks with symptoms like palpitations, arrhythmias, or fainting should be prioritized. Follow-up assessment of these family members is indicated. It's also recommended that, if possible, that these families attend a specialty clinic. And I'm a big fan of this. I try to recommend to any of the families I talk to that they go to a specialized center where there are experts. If it's only once, to travel to somewhere where the folks know how to deal with these cases, what the appropriate tests are, and how to interpret them is very, very important. There are also a number of support groups for families. I list just a couple here that I've had the opportunity to work with over the years. These families need ongoing support, and while we may see them in clinic once a year, there's a whole community of people out there who have lost children, and it's important for them to have that support. So what's currently happening to address what we don't know? There are a lot of current resources and activities to better understand sudden death in the young. One that is near and dear to my heart is the Sudden Death in the Young Registry. What's great about the Sudden Death in the Young Registry is that it is incorporating a lot of these recommendations into practice. So the protocols and processes for the Sudden Death in the Young Registry include saving appropriate samples for DNA, splitting DNA samples based on consent to allow for family banking for research, including recommendations and referral information for family screening, genetic counseling and support, and consenting procedures focused on the family. We have developed a number of tools to address what often causes sudden death in the young. This is a picture of our SDY Autopsy Summary, and it's focused on the cardiac causes, the neural causes, and the infection causes that we would anticipate seeing most often in young sudden death cases. It follows a checklist approach to make it more objective rather than so subjective, and it's available. I can send you copies, or you can get it from the NIH facts page on the SDY registry. There's also an SDY field and family form, and I wanted to point out that although it's not as comprehensive as what a genetic counselor or other genetic specialist might take, that this field and family form incorporates family history, which is something that has often been missed during the death investigation in these cases. So the purpose of the Sudden Death in the Young Registry, which is a collaborative registry between the National Institutes of Health, the Centers for Disease Control, Michigan Public Health Institute, and the University of Michigan, is first to establish the incidence of sudden death in the young in the United States, and second, to investigate causes and risk factors for sudden death in the young. So we want to know how many children die young and suddenly in the U.S. each year, and what are the characteristics of those cases so we can eventually develop better prevention strategies. Phase 1 of the project has been focused on developing a surveillance system and creating a registry of these cases. When the deaths occur, a biospecimen for DNA extraction are being collected. The second phase of the project is to make the data available to investigators and the scientific community. and to support mechanistic, genetic, and other studies which use the registry to evaluate causes and risk factors for SDY. So as I mentioned, this is a very busy slide, but it is a collaborative process between multiple organizations. Under the NIH, we have the National Heart, Lung, and Blood Institute and the National Institute of Neurological Disorders and Stroke. In the fall, the CDC funded 9 grantee states. Some, as you can see by the star, are only in selected populations. For example, the County of San Francisco and the Tidewater region of Virginia. These states have been working very hard since January to implement the registry. We work with them through MPHI, where the Data Coordinating Center is housed, and the University of Michigan is our biorepository. As the registry progresses and samples and data are saved, those samples and data will be made available to investigators during the Phase 2 research. The flow of cases brings some new players to the table that you may not be as familiar with. So the sudden death in the young registry is active surveillance. So we hope to capture all the cases ages 0 to up to age 20 in the funded jurisdictions. These cases will undergo something called child death review that happens in almost all of the states in the United States. At child death review, the cases will be reviewed, data will be collected, and ideas for prevention will be discussed. This team will decide, based on our SDY categorization algorithm, which cases need to undergo advanced review. So cases that are accidents, homicides, suicides, those will be eliminated. Other cases where it's sudden unexplained infant death, it's cardiac death, it's neuro death, those will proceed to the advanced review to eventually be categorized so we can better understand the incidents. Parallel to that, during the case, the medical examiner who completes the standardized autopsy form will save a purple top tube and send that to the biorepository so that in addition to the data we collect, we will also have a DNA sample. There are other resources available as you start working through seeing postmortem cases. The NSGC has had a postmortem working group for a number of years now, and this was a program initiated through the National Society of Genetic Counselors to connect genetic counselors to medical examiners. This group serves as a referral resource. It's helping to implement recommendations for saving appropriate samples and making sure families get screened. And we are working to develop resources for families. We have developed an information sheet for families who are attempting the genetic testing process on their own, and hopefully they'll get in touch with a genetic counselor or someone with genetics expertise. And we're also working on an insurance template for families and practitioners who would like to attempt insurance reimbursement for postmortem genetic testing. We have also been working with the SADS Foundation to provide a mailing to medical examiners. This picture is actually a magnet that can be put on the fridge in a medical examiner or coroner's office that shows in a flowchart format the name recommendations. It also gives ideas for which cases where samples should be saved for genetic testing. So the point of all of this information and all these ongoing resources and research is to eventually lead to prevention. It's important as you consider how are we going to make this better, who you're working with, and how you translate this information to families. I think that the highest risk group of people and the risk group that we work with most often are the families. If someone in your family has died young or died suddenly, we really need to work with preventing death within those families. But prevention can be more global. There's many, many things going on in terms of for the babies, making sure they're in safe sleep conditions, for coaches, making sure they recognize the signs where a child might be having a heart problem. And those things will continue to evolve as we better understand. But I encourage you to build your team. In the end, if we build our teams, we will help these families live longer lives. And I think genetic testing can definitely help, perhaps, if we can identify this child at an early age as having an inherited susceptibility to cardiac arrest or sudden death, that we can help them live longer and hopefully reach old age. I'm providing some information here about how to find a genetic counselor. There's a couple different resources through NSGC. And there's an ongoing initiative through our Postmortem working group to provide information, and again, pay it forward. As we're learning, we want to be sharing it with families and practitioners. So there is a lovely website that Sam has put together, as well as we have an email group that has recently expanded to also include metabolic genetic counselors. There's cardiac genetic counselors, metabolic, and we anticipate it will continue to expand as our understanding of what causes these deaths expands. I'd like to acknowledge my colleagues from the Cardiac Special Interest Group. It's a great group, and there's many, many good things and good people there. I would also like to acknowledge the SADS Foundation for working through the medical examiner mailing project and keeping it going to improve education amongst the medical examiners. I would like to acknowledge my colleagues at the Sudden Death and the Young Registry for both reviewing my slides and for being a great team to work with as we implement the SDY registry, as well as our advisory committee, autopsy protocol committee, and ethicists we worked with in developing the SDY registry. Everyone is always very helpful in answering my questions as I learn the languages of all the different groups.
Well, all right. Well, feel free to reach out to either me directly or Heather with any questions following the webinar. The webinar will be available on our website very shortly. It usually takes us a day or two to get that up on the website. So if any of the colleagues missed it, feel free to watch it there. And thank you, everyone, for joining us.